final short talk in this session is by Dr. Faissal, who is going to talk on suggestions to improve recipient and donor registries and sharing of network and sharing of organs through a network in the GCC countries.
Again, Bismillah ar-Rahman ar-Rahim. It's very difficult to speak after such eminent two friends, Tim and Sire. But it's good again that I have a very completely different issue. It is related together, but it is not in the same line. And Sire was speaking about some important steps which we should go for funding of the research between the GCC countries, which I think one of the important issues, more than the issue which I'm going to speak about. I suppose to speak about the registry, which we supposed to do it long time back in order to know exactly what we have. We have numbers, but we don't have actual registry in GCC country. I will try to go quickly to see what's mean by a registry and what's important to have such a registry in GCC country. Any registry anywhere, even for any disease, at least if you know the incidence, you know the prevalence, and you know the survival, you can know the cost and performance of the peoples also, how they deal with any disease. And this can help you for sure to make your plan and to overcome the obstacles which you face. Without statistics, without survey, without without registry, you cannot do anything of that. So everyone will go in his own directions. It should have similar features as general registry. This is important, and we should have some place, important or authorized place to see all the registry and to have a contact and power to all the hostel in order to make a registry. We cannot make a registry from just only one place and different place. I know that some people within the same country have different registry. And if you ask one of colleague from X country how many patients you have, he can give you different number from the others which you ask from the same country at the same moment. So we should have national centers to supervise organ donation and transplantations and registry of organ failure patients. So legislations of the government authority, it is very important also in order to have such a registry and to collect the data from different places and to have the power to collect that data. This is again just to show to you what the importance of the registry. If we have registry, this is from SRTR, and you can see over a long period graft survival, patient survival, what is the incidence after how many years. We have it again in Saudi Arabia, but in many countries we don't have it. We would like to have it in all the GCC countries. And it's why that we have a committee. We are meeting almost every year, but still we don't have actual registry. We are looking to have such actual numbers of patients and survival of patients in the next. This is again from SRTR. You can see again how is the transplantation going with the kidney, liver, heart, and lung. Again the outcome, again the outcome in 10 years, in 4 years, organs, plus, minus. This is again put for you the strategy to plan for the future and how to overcome the problems. Waiting list, how big is it? What you are doing in the transplant activity? What is the gap? How to overcome the gap? This is all is very important for us to know it by doing statistics. What we had now in GCC, our status in GCC, from my own point of view, I think we should have national centers in each country, and we been suggesting this since 1994 that we should have a national organ centers in each country. And if we look for all the GCC country, new A till now we don't have. Legislations for transplantation, we have it in all the country. National registry, we have it only probably in Saudi Arabia because it is since 1984 we have registry for all the patients. And if we look for Yemen, they don't have national registry. They don't have national center to supervise all the transplantations, which we also, this is our request, maybe after this Congress, we are going to write that we should have a center in all the GCC countries. In Oman, they don't have till now. Before, they have small organization, but they don't have as a national center. In Kuwait, they have a national center for organ transplantation. In Qatar, they started to have centers, and hopefully it will be very active. Here it's certainly not very applicable, but it is there, and hopefully, because again, the number of the hospitals is small and it was easy to see. But still, we don't have a core persons, one person to speak with in just such country. In Bahrain, they are going to do it, and they are very, very enthusiastic to have such center very soon. This is again the activities, the performance in transplantation. All this data is not from registry, it's coming from our committee, GCC committee. Everyone present what he had in his country, and I'm sure that some of our colleagues from different countries, they had a very hard time in order to collect the data from different hospitals because they don't have it online, they don't have it in one place. That's why our statistics, which probably it is plus minus 10% in Saudi Arabia, but in other countries maybe it is completely different from what we had. Registry again it's very important, and it can make collaborations between the country also, and future-wise we can have good organ sharing, and we can even give the best organs to from the best recipient to best donors, which or vice versa between our countries. And we start organ sharing program between our countries, and now we reach a good number, 178 organs between us and Kuwait and Qatar and Bahrain, and hopefully we will go further, and Muscat, Oman, and we will go more, because now there are some activities can be shown in Bahrain, and good activities in Qatar, and I'm sure in Abu Dhabi very soon we will have at the end of this year and UAE some good activities, especially in disease program. This is again the organ sharing, as you can see, between Kuwait and how many kidneys, livers, whole heart, lung, and this is what we are doing now. But still, what we need is a lot. We are doing our best, but for each 200 kidney in patients needed in GCC, the available kidney for them is 20 only. And for liver, we think that 50, if every 50 we provide 15. For heart, every 20 we provide 2. For lung, every 20 we provide 2. And cornea, we provide 100% for the required, the patient required cornea, but 30 coming from inside and being imported from outside. So I will return back to the same slide, which I have it also. If we want to do something, we have to go over or at least to overcome the religious and social acceptance which we had. Second, to have government support. GCC all have government support for the transplantations. And procurement center, it is not applicable in many of the GCC country in order to make a registry. Again, if the famous slide which showed that the income goes with the transplantation, if we have more income, we'll have more transplantation, and if we have less income, we have less transplantation. This is, I'm sure that the exceptional is probably in Iran, because they have a good program of living unrelated. But if we look for the Saudi, sorry, for the GCC here, we'll find that this is a very important. The income is good, so we should have a good transplantation. That's why we should work in that. This is again shown everywhere, that if you have a good income, you have a good transplantation program. Our problems before is that our patients are being deviated, or at least being shifted to look for transplantation abroad. And this case will not continue. And this is a slide which we make it a long time back, and still it is, we name it as unethical directions of transplantation. So the people from the Gulf area were going especially to Asia, especially to some places to South America. We don't have so many of them, but in Gulf area they were going to to Africa and some Asian country without names now, and to get a transplant. And their ethical way, which it was even the donor and the recipients go to some Europe and to North America in order to be transplanted there, just because either they are rich enough to go to do there, or they don't like the people to know about them. After declaration of Istanbul, and again the fight against organ trafficking and transplant tourism, all of this make us think about that we have to depend about ourselves in GCC country. And this meeting, most of this meeting, we were together, been with them as a part of them. And here you can see Sire is always there, but they miss me. I am in one of those things. I cannot even recognize myself. I don't know, maybe some people who are taller than me, and I was behind them during this talk, this picture. So I will come to Madrid again, the Madrid meeting, which is important, and it was through the WHO, and we showed, and it showed that every country should depend about themselves. There is no more countries send their patients abroad to have to take organs, and this will be, the fight will continue and continue, and that's why each country should depend about themselves. And this is the accountability of the government, what they should do. They should again make prevention of the disease, they should register their patient, they should give service to the patient, and this is the recommendation of WHO in guiding and the principle for health service. What's happening in GCC is the same what's happening in Saudi Arabia. We have so many patients before going abroad for transplantation. We reached in one state that 723 kidney patients in 1 year went abroad to get a kidney from Pakistan and from Egypt and from India. And these numbers stayed for 2004, 5, and 6, and then 7, and then when we have Istanbul declarations and people start to fight it, India closed, Pakistan closed, China started to close for a period of time, and then the number decreased dramatically. So that, and we started to have a good number in our centers here. Now we are going to reach probably this year to around 700, 750 patients transplanted within the kingdom, because all the doors start to be closed outside. We have so many obstacles that the national center are still not available in most of the GCC country, and this is our responsibility as a member of GCC in order to push the government to have a center there, the government, which it doesn't have. So we still looking for government support. We have to have legislation, which we had it already, but we have to initiate it again to bring whatever we decide before, and we should support those centers by budgeting enough in order to improve their work. Our future consideration is to improve the cooperation between the GCC countries and also with the countries not in GCC. Because we start as a Saudi, we had started to have collaborations between Saudi and Tunisia. We start to have collaborations and work between us and Jordan, and we are going to have something between Saudi and Lebanon very soon also. And this is a very important issue that each country, if they can have another collaboration, we will work together. And as you know that, again, as GCC countries, there is another 2 countries is coming very soon to be part of GCC, but probably I don't know whether they're going to change the name or not, Jordan and Morocco, and probably this also will lead us to make more cooperation between the other countries. So we will catch Morocco up and Jordan and Lebanon, and I'm sure that some other countries will join the GCC in the future. I think again the solution, we have to expand the funding resource, we have to establish national organ procurement centers, we have to encourage a network organ sharing, we have to have more exchange of experience in national program, and to benefit from all sources of organ donations in GCC. Thank you very much. If you allow me, Dr. Timan, I would like Dr. Salim, I think he is still with us here, from Oman. Dr. Isa from Oman, please, and Dr. Mona to join us in the panel. And Dr. Saleh Aswad, he is, everyone know him, he is the one initiate the National Kidney Foundation, or start as a first director of National Kidney Foundation in Saudi Arabia, to join the panel, because I am sure that they can have a good input with this. Please. Is not here anymore.
Okay, so we have had the 3 introductory talks, which will probably start initiating the discussion or the panel discussion. Being a chairman, I have the privilege of probably starting myself. And my comment to Tim's talk, which was excellent, as if he's been here for a long time. So he was aware of the problems that we are facing in the GCC countries. I'd just like to point out regarding the composition of the population in the GCC countries, and as you all know that expats constitute a large portion of the population. In Kuwait, it is 2/3 of the population are expats. In other countries like UAE, I think the numbers are even the greater, the percentage of the expats. I don't know the number of expats in Saudi Arabia, but again, there's a large community of expats in this country. Now, Tim pointed out that this might be a hindrance or a problem regarding establishing organ procurement because of the many barriers, cultural, language, and whatsoever. And I think one solution to this is that to get these expats involved in the process of not only donating, but also receiving organs from deceased. To my knowledge, that the priority goes to the nationals in all GCC countries. I know this is happening in Kuwait, that in the past, only Kuwaitis if there were no suitable Kuwaiti recipient, then the organ or the kidney would go to the non-Kuwaiti. And I've been trying to change this over the last 2 or 3 years, and finally we have got the agreement of the departmental meeting of the department of the transplant, department to include the expats, because I believe expats are donating, they should be also given the chance of receiving, and that will encourage more expats to donate. And maybe one way of involving the expats is to let them carry donor cards whenever they come to work in Kuwait. And we tell them, if you carry a donor card, then you will be included in receiving. So if you are willing to donate, you will be also given the chance to receive if you need an organ yourself. Not only that, to receive organs, but also to receive free dialysis, which is only available to Kuwaitis in Kuwait. I don't know about the situation in Saudi Arabia and other countries, but I think it is probably similar, that non-nationals have to pay for dialysis. So we can say that if you carry a donor card, and then after many years of working in the country, if you get renal failure, then you'll be provided with free dialysis. I think that will encourage more expats to carry donor cards and to hence increase the number of donations. I don't know what is the feeling of Faisal and also the other members of the panel on this topic. So expats will receive.
I understand very well what you mean, and I don't know either if we look for the percent-wise from national to non-national in the government and in the GCC country, it is completely different. I agree with you that we should give the service to non-national in order to encourage them for donation, but you mean disease donation, isn't it? Or living?
No, we are talking about disease donation.
Okay,
yes.
Thank you. If it is living, I don't think that it is applicable, and it will be very unfair, because we have too many expatriates working in our homes and as a driver and housemaid and everyone. If he wants a kidney, he can easily take one of those and take their kidney. That's why it's better to avoid it in living at all. That in Saudi, we have living unrelated program, which I think is very successful, and the things which make us proud of this program is that we make it national to national. So no one allowed to take a kidney from his housemaid or from the driver or something like this. We stop it. But for disease donation, I agree with you that probably it can work, but this is you have to differentiate between people who's coming as a temporary work or people who are non-citizen and they are having permanent citizen or permanent staying in the country, permanent residency, which again is a very big difference between the two categories of non-nationals. But it is excellent idea. I agree with it. Not in a very deep to have it for living. For living, it is not applicable in GCC countries.
In our country, we obviously have, it's sort of the other way around. The notion has been in the United States that there would be people who would have excess money who could come in and buy organs or to access care. And so we have put a restriction on the number of peoples who can actually access deceased organs who are non-nationals of the country. What we're dealing with is a really simple problem. There's a certain amount of resources that are inside of a country, and the question is, how do you give them out? In the GCC, where you have such a large percentage of people who are non-national who work in the area, they end up as being a significant percentage of your potential donor pool, which comes from expatriate population. And the question is, in the sense of both fairness to your native population and the nationals and to the people who are working here, how does it fit? And that's the questions of access to care is a real one that is going to have to be dealt with both country by country as you come up with it, as well as as a society. In the U.S., we have the 5% rule, where 5%, we can transplant 5% of our total number of transplants with foreign nationals. Turns out that that is almost the same number as the number of the percentage of donors who end up coming from outside the country who die in the United States, who then donate organs. So it's almost an even balance, which is how we can continue to deal with our Congress on trying to move forward. But it's a much more significant problem in this part of the world than it is in either our part of the world or potentially as much in Europe, although with the changing EU zones, they're really struggling, I think, with moving of people across borders.
I think this 5% rule is being, there's a discussion now going on in Yunus that this will be removed or will be abolished. Are you aware of this?
Yeah, it's been part of the dialogue for a long time. There's a very strong sentiment, though, within the country to either get rid of it entirely and not pay attention to nationality in terms of allocation, so that it can float up or down depending. And particularly with our large percentage of people coming from across our southern border, from Mexico and from the South American components, there's a strong move afoot to say that residency is less important. And then on the flip side, there's a number of people who say that only Americans should get American organs, and we have a lot of conflict, which is why we still have the quota.
I personally think still that this 5% will give a chance for patients who are dying of certain extrarenal organs like heart or those that you cannot get from the living, to a chance to go somewhere and get a transplant. And I think abolishing this 5% will really abolish this chance. So I think it should be kept on a humanitarian basis, that at least give a chance for some patients who don't have access to organs in certain parts of the world to come to the United States. And I think this is good for the image of the United States.
I agree.
Before we move to another point, any comments from the other members of the panel, Isa or Mona?
Yes, just about the slide regarding Oman, Faisal mentioned that's probably before 2005 or before that. Because since then we had at least 20 plus of life-related, plus from one particular hospital, Royal Hospital, and from university about 3 or so per year. So in terms of population per million, that will be more than simply less than 5 per million per population. So probably that's old information as far as Oman is concerned. And as far as cadaveric, as you are aware, we don't have it as a proper system. But we have more than 15 now cases done, and these are cases mostly US and UK citizens who've been living in Oman and serving in their country, and they passed away of some of their relatives and they donated their kidneys. But the rest of it, mostly cadaveric done, or liver and the rest of it, more than 150, but done overseas. And we had a handful of cases, whether heart, liver, and kidneys from the United States for some of the citizens. They simply were living there, visited for one reason or the other, but without any sort of financial incentives. But dialysis-wise, as Mustafa mentioned, or transplant, if the actual individual expat is working in the government sector of Oman, will provide free service, including his medication and the rest of it. As far as working in the private sector, that depends on his company. But even recently, a Filipino guy, his company was private and small. They were happy to provide his dialysis and pay for all the expenses as far as he's still working with them.
Can I comment, please? Thank you very much. I was putting one question here for you, that Oman, as probably most of you know, that they were very active before in transplantation when Dr. Abdullah Dar was there, and one of the very important GCC countries would share organs as well. Ourselves, we send organs to them long time back, and then we have a plateau stage where we don't have any such activity. I went many times for a congress to promote the organ. I met the minister, I met the deputy minister. I have a lot of promises, but it's not going on. I'm quite surprised that you have donors from these donors, and we are not aware. We should be, as a GCC, can know each other, and if you are not using the liver, we can use the liver, the heart we can use, and there is agreement between all the GCC country and others, even to Saudi can transplant patients, Omani patients, and we transplant one recently actually from deceased donor if we are sharing the organs. So I hope that this relationship between us will return back again, and we will start to work again in this. And I'm happy to know that the program start again, and because a lot of effort to being done before by Nabil Salmin, we should also remember him in this Congress, in order to overcome the obstacles in administrative obstacles in Oman. And I'm happy that you did that.
In fact, there was, as probably aware, the changes in the admin at the Minister of Health in Oman, and things will, I think, will improve now. They will have a bit of difficulty at that time. But I think there are good scopes for really getting the liver and the rest of the organs from people who have.
Okay, so Mona, do you have any comment regarding the first point that we discussed regarding the expats? Because you have a large number of expats. I think, what is the proportion of expats in your country?
They said officially 80%, but I believe it is more than 90% or 95%. The truth is, in the Emirates, still the disease organ program is not activated, although it is approved by the Minister of Health, but it seems it has to pass through the Minister Cabinet. So it didn't reach there yet, so it is not activated in the country yet. But in the future, I believe, if it is activated and we have expatriates who are on dialysis, then we are obliged to put them on the waiting list. And then, according to the organ, I mean, if we are going to receive the organ of the expatriate, then they have the right to receive the organ also. Most likely they will. Because now, in fact, all the expatriates who have a live-related donor, they are accepted for transplantation free of charge.
Sure, sure. Okay. Thank you very much, Mona. Before we open the questions for the audience, I'd just like to ask, have the opportunity to ask Dr. Saleh Aswad, who's worked both in Saudi Arabia and in the United States, and listen to his suggestions of how to improve the situation and the programs in the GCC countries.
Thank you very much for the organizing committee. It's a very, very nice meeting. When I see you in Saudi Arabia, or when we start 15 years ago, and what you're doing today, I don't know if anything we can adding to Saudi Arabia for this program, and the staff working with Dr. Faissal Shaheen, and the way they're thinking, and the projection, what they're doing. We are very, very proud what you're doing in the SCOT in Saudi Arabia. As one comment only, I don't know, unfortunately, the last 4 or 5 years, I'm not involved directly in the transplantation and donation. I create lab in United States only for donor, for infection disease. The last 4 or 5 years, a lot of lawsuits in the United States for hepatitis C, for hepatitis B, for HIV, because what we're testing in serology only. And I create lab, we can give DNA testing in 2 hours only. It's very new technology. If you look the last 4 or 5 years, a lot of tuberculosis from donor, coming from donor tuberculosis, Nile disease, Chagas disease, CMV infection. I don't know, really I don't know what the level of the lab here in the United States testing the donor before the donation. This is what I suggest for the program here. The second, what I suggest, we do a lot of research on the donor. I have a lot of, I don't know how many papers I published about the donor, donor criteria, extended donor criteria. machines, the machine, procurement machine, we use it for 500 times. I don't know what in Saudi Arabia, unfortunately I don't know what they're doing, but I suggest more research and research. Because the research is the base of the donation, as Dr. Mohammed Sayer mentioned. The key of our success in the United States is research, and we do research and research and research. 5 years ago, I have 140 employees doing only research in National Institute of Clinical Research in Saudi Arabia. This is what my